Welcome to the Everything Cancer podcast. This podcast is intended for survivors, those who love them, healthcare providers, and leaders of cancer support organizations. Our guests offer insight into the honest survivor experience, how challenges are met head-on, and where blessings are discovered. We cover effective self-advocacy on the bumpy road of cancer survivorship from the moment of diagnosis on. We talk about rekindling intimacy when cancer has changed your world. We are given behind-the-scenes insight into cancer care because understanding it better empowers you to advocate for yourself more effectively. We hear from leaders of cancer support organizations about their resources and how to access them or those like them. The Everything Cancer podcast welcomes survivors who would like to share their journey and how they have met their challenges, providers who would like to share their empowering insight, and leaders of cancer support organizations who would like to share their stories and resources. We welcome support through sponsors, the Everything Cancer website, and our Patreon page. Please note, the information shared on the Everything Cancer podcast is not intended as medical advice. Please always consult with your healthcare team. The staff at Everything Cancer podcast will not answer individual healthcare concern questions. Thank you for joining us, and we hope that you enjoy this episode and find it useful. Please do share it with other people if you think they'll benefit from it, and rate us on your favorite podcast platform. Thanks and take care. Hi, everybody. Welcome to the Everything Cancer podcast. We have the pleasure of having Mark, a clinical oncology pharmacist, here with us today. And I know how important his role is, but I would love everybody else in our audience to understand how important his role is in protecting your health and helping you have the most optimal results you can from your treatment. Mark, thank you for being here today.
Thank you, Jill, for the opportunity. I'm excited to get to talk to you.
I'm so excited to have you here. So, Mark, can you explain a little bit of what a clinical oncology pharmacist is compared to, say, a mixing pharmacist? And then can you walk us through, when you get a treatment plan for a patient, your interaction with that patient and with their treatment plan and the other providers, such as their oncologist, that are part of their care?
So one of the kind of unique things about my role is I really don't even see medications anymore. So it's a very unusual, different site. I actually work up in our center on the third floor with all of our oncologists, advanced providers, and do a lot more patient interaction, direct patient care, talking to the patients, discussing with clinical providers, that kind of thing. And so it's a much more focus on the information than it is the actual medications themselves and handling and mixing and things like that. And so, as for giving you an overview of what kind of I do on a day-to-day basis is when a patient, comes into the cancer center, they're diagnosed with cancer, the provider comes up with the treatment plan that goes into our system, and then one of their primary nurses, they basically put on my calendar an appointment for that patient to meet with me and kind of go kind of a full overview of that treatment plan. And what that looks like is I kind of get notified ahead of time. So I work up that patient. And as far as like working up the regimen itself, I make sure it's appropriate for the disease state. Everything looks right from a dosing standpoint, from labs, clinical workup, as much as I can going into the actual discussion with the patient to make sure we're on the right track and everything seems appropriate. And so I can head off any problems before we get to that point. And then hopefully get to meet with the patient in person. Always used to be in person pre-COVID. Now with COVID, obviously we had to adjust things a little bit there, but now we're kind of getting back to in-person. I definitely think in-person education has much more value. You get to kind of interact with people more directly versus over the phone. But anyways, once we meet with that patient, we kind of give a full gamut. So we start with, basic stuff like schedule. Where are they going to come? Where are they going to show up? What time are they going to come? And then get into the details of the actual regimen itself. So looking at pre-treatments, we talk about the antiemetics, we talk about the drugs themselves, kind of just how long they're going to be here. That's always a bit of a shock as, when you tell someone they're going to be in the chair for 4 hours, 5 hours, 6 hours, which is kind of the average. I'd say 4 hours is pretty normal. That's a long day. And so we just cover, again, pretty much everything. Talk about bringing snacks, bringing blankets, games, puzzles, whatever it may be that they kind of entertain themselves. Also, I try to give them a tour if they actually are here in person. I try to show them the exact area where they're going to be getting the infusion. if possible, and that can definitely alleviate some of the anxiety of the unknown, of not knowing what it looks like. And
Mm-hmm.
at least at our space, and I think most infusion centers, cancer centers, it's a pretty welcoming space. It's pretty,
Mm-hmm.
it's not as maybe sterile as maybe an inpatient type setting. But we go through
Mm-hmm.
that, we go through the schedule, and then we kind of work our way through the treatment itself. And so one of the first things I do is do a medication reconciliation. So I have a patient review with me their entire med list. Typically, I have a baseline up front, so I've already have some idea of what they're going to be on and any potential interactions. And then I update that based on what the patient says. And then one of the key things I always ask is, do they take any herbal supplements, any over-the-counter medications? And especially in oncology, I think we are in a field that um, allows itself to have a lot of recommendations to take maybe non-traditional medications or non-approved medications. So it's very
Right.
common
Right.
that I have someone who is taking something that is maybe not FDA approved or that they had a friend recommend. I've seen anything from shark cartilage to the more common stuff like turkey tail and things like that. And
Mm-hmm.
one of the big conversations I have with patients is that that's great. It's great that they're able to take some of that control, have that autonomy, and get to feel like they're adding something to the equation of how they're helping to fight their cancer. But
Mm-hmm.
on the same side, we want to make sure it's being done in a safe manner, right? And so that's what I feel
Right.
like from a clinical pharmacist standpoint, that's kind of where I get to dive deep into how do these supplements work, at least to the best of our knowledge. And we really have to look at what treatment medication or what the treatment mechanism is. And so a lot of the traditional chemotherapy agents, your taxanes, platinum agents, things like that, they oftentimes don't interact with a lot of supplements. They just typically don't. But now we have a vast amount of oral agents, and a lot of the more targeted oral agents, they do interact quite significantly with a lot of those herbal supplements. And so really diving into which ones work which way, I think one of the hardest things that with those discussions is a lot of times there's a lot of buy-in to those herbal supplements more than the traditional chemotherapy
Mm-hmm.
drugs that they're getting. And so really trying to
Mm-hmm.
navigate, we don't want to have patients feel like we're just shutting them down and saying, no, you can't take that because we didn't tell you to take that. We want to really try to, again, empower them to feel like they're having some input into what they're doing to fight their cancer. And
Right. But it's not even just making them feel that way. You truly are doing that. You are giving that control and empowerment to them. So, anyway, go ahead. I'm sorry.
yeah, thank you. Yeah, no, thank you. And so the way I approach it is if I can, I basically have a couple of different databases I go through, and if I don't see anything that says that it's likely going to interact or likely have issue, I still have to give the disclaimer that we don't know for sure. There's not clinical studies showing the
Mm-hmm.
exact interactions, but we can at least give an idea of what the impact would be. But on the flip side of that, if there is a potential interaction, and I'm usually pretty conservative in my recommendations, I recommend they don't take it. And the best way
Mm-hmm.
I feel like I come across doing that in a agreeable manner is things like grapefruit juice. You'll see that listed on multiple medications that grapefruit juice interacts, and same thing with cardiac meds. There's a lot of cardiac meds that have that same interaction, and it all stems from the enzymes in our body and how they break down drugs. And if we alter how those enzymes work, we can either increase toxicity or decrease toxicity. And I usually try to go that in depth with patients to try to help them to understand why we're giving those recommendations.
Mm-hmm.
But we'll
So
go through
you're
that.
letting them more empowerment by doing that, increasing their understanding of why this. You're not just saying you shouldn't do this. You're saying, hey, this changes your enzymatic interaction or your body changes the process of how you digest these drugs in this way. And so you explain to them the full picture so they can make a really informed decision.
Yeah, and it always amazes me the questions I get from patients. They definitely do their research on some of the in-depth stuff, and it's not uncommon that I am going away from the conversation with the patients, having to go research myself what they bring to the table. So it's pretty amazing those
Mm-hmm.
conversations they're able to have. Obviously, each patient's different. You have to tailor how you present that information to that individual patient. But yeah, it's usually a great conversation.
Mm-hmm.
Yeah, so we go through all that. We'll make sure everything's safe and reasonable to proceed. The next thing we'll dive into is side effects, and that's usually obviously the most pressing question patients have is what am I going to experience? What's going to happen when I take these medications? And so we'll kind of work through our side effects, try to cover the more common stuff first. We have some great handouts that we use that really highlight some of the more common side effects. So without going too in depth into the more rare things that occur, but then at the end we do cover some of the more rare things that can be severe. So when it says a heart attack might be an issue, we do cover that. We highlight that this is rare, but we want to make sure patients are able to have the knowledge to know how to respond if that something like that were to pop up. And we work through side effects. We work through side effect management. One of the other big roles I play is all the patients have my direct number and basically provide supportive care. And so whether it's patients calling us directly reporting side effects, which I always encourage them to do, or I also call patients about a week or two after they start each cycle just to check in, see how things are going, just to add an additional touch base in between when the providers are seeing them and when they're coming in for infusions if they're in an infusion type treatment. Other nice thing about that is we have a collaborative practice agreement, so I'm able to prescribe a variety of things like antiemetics, antihypertensives, some GI supportive care, which depending on what state you're in and listening from, that may vary on what you're allowed to do or able to do. But in Michigan, we're allowed to have a collaborative practice agreement with our providers, and so that one allows us a lot more autonomy as pharmacists to do those kind of things, but also helps get patients treated or managed quicker. It also takes some of the workload off of our providers, so they're not having to do things that we are fully capable of doing without kind of their additional oversight. And so we do that. Then after we kind of go through all the side effects, help manage that, that's the bulk of the education. Then we cover some safety precautions. And so these are hazardous drugs, right? They definitely have their risks. We want to make sure patients are taking it in a safe manner from an oral standpoint, safe handling, making sure no one's accidentally getting into the drug, avoiding pets, kids, all those kind of things that standard stuff you'd go through. And then also from a body fluid standpoint. So not only basically exposure risk. So unfortunately, there's a lot of stuff out there that makes patients feel like they're glowing in the dark, something more severe like that. And that's oftentimes not the case, right? We know that there is potentially some drug and body fluid. There are some risks, and some pretty basic precautions help mitigate the vast majority of that. And so, yes, educating patients on the risk potentially of that, but also I feel like a lot more of what I'm doing in that situation is kind of calming patients down and having lessening that anxiety of, can I, touch my partner? Can I, kiss them? Can I hug them? Can I touch my grandkids? That's a big one, especially holding grandkids, babies. And it's oftentimes more relief to them when I go through that information that they can still see family and do a lot of these things that they're previously very fearful of. So that's kind of a general overview of kind of what I'd go through in my initial meeting with those patients. And then,
So how do you interact with a patient, say, oncologist and the infusion nurses?
Yeah. So the oncologist, one of the great things about where I'm located is I have a wonderful relationship with all of our oncologists. They will knock on my door, they'll come down the hallway, and vice versa. So anytime there's a clinical question, I mean, anything from more complicated stuff that's obscure, where we're both kind of trying to dig through the data and figure out what the answer is or what the best answer is to that situation, to some of the providers will actually have me just dose their like oral agents like capecitabine and things like that. So it all depends on the provider and how they utilize me. But yeah, I have a great relationship with the oncologist. And so again, one of the very unique things about where I'm located, my role is that we just get to work together. I get to take a lot of the workload off of the providers. Prior to being in my role, the APPs, like the nurse practitioners, they in our site, nurse practitioners with PAs, they did a lot of the stuff that I'm currently doing. And so by me taking over that role, that has allowed them to see more patients in their situation, and then which has further allowed the oncologists to see more patients. And so it's further been able to maximize their use or practice at their level, that they're practicing up to the maximum of their level. Yeah, and then
I'm really interested to go ahead. Go
ahead.
No, I was just going to say it's very interesting what you're saying as far as the role you're playing, because a lot of what you're talking about, I'm very used to, as you were saying, the nurse practitioners and the PAs taking on those pieces with the patient education and talking about the safety and so on. And so I do see a lot of benefit in them being able to spend more time with the patients that are having problems or the patients that are recently diagnosed, to really do deep dive into that patient and you're helping tremendously with your well-being, but you are giving them time to do more of the troubleshooting aspect with their condition, their diagnosis, and their just how they're doing in general from a side effect management standpoint. If what you're initially prescribing isn't quite working from the side effect management standpoint. So I am fascinated, and I really see the benefit of that from being involved in operations of things like that. So what were you going to say?
So at the end of that, if a patient comes in with a rash or something like that that needs assessment, nurse practitioners, PAs are much more trained at assessing that. Like when patients will ask me to
Right.
look at something, I can look at it, but it's not going to be as useful as an NP or a PA, someone who's better trained in that. And I'm very well trained in the drugs and the treatment plans. So I think, again, maximizing our skill set is a great
Right.
benefit.
Right. And you're very well trained in the first level and second level of side effect management with what is possibly prescribed to help manage that. And I like how you're saying that you can take that and run with it too. To again get the patient their answer sooner and not have a delay with it having to go to another person and the order put in. So how do you interact with the mixing pharmacist, Mark?
Yeah, so one of the another nice benefits of my role is prior to me being here was you caught a lot of the issues that we may come across, whether it's incorrect regimens, which is uncommon, right? Providers are usually they're doing the right regimen, but sometimes there's EMR issues, glitches, things like that. But coming across those dosing issues, weight changes, things like that, all that stuff that typically we would catch the day before we're doing patient workup, or even sometimes the day of when the patient's in the chair, we're able to head that off up front by getting those regimens cleaned up, identifying any issues up front, which has streamlined a lot of the function in the infusion pharmacy. So that has been a great, again, further optimizing our role in being able to allot more time to do other projects that we want to.
Yes.
And then
Being on top of weight change is really important because it can increase the toxicity of the drug if someone has lost weight, or if they have gained weight, they're not going to necessarily be getting enough for optimal benefit. Thank you for tuning into the Everything Cancer podcast. We appreciate you being here with us. If you are finding this episode useful, please share it with others that you think would benefit. And don't forget to rate us with your favorite podcast platform. Please check out the show notes for more information and more information about our guests, links to their websites, and any other resources they've shared. We aim to make it easy for you to connect and learn more about the valuable insights shared in each episode. We welcome support through sponsors, the Everything Cancer website, and our Patreon page. Please stay tuned for a brief word from our sponsors, and then we'll be right back to our episode. Thank you so much. Do you have a dry mouth that distracts you with that nasty feeling and taste? H2 Ocean has your solution, literally and figuratively, with its sea salt healing rinse. It's made from salt from the Red Sea, and it has other minerals that are beneficial to you in it. It also has lysozyme enzyme, which is soothing to the inside of your mouth, and xylitol, which makes your mouth water. It's very mild in flavor, yet refreshing. Does not make you suck in your cheeks like often happens with other mouthwashes. And it stays with you. Other mouthwashes, they're gone in 10 or 15 minutes. This has stayed with me for a few hours now, and it's great. I plan on using it before every podcast episode to keep my mouth moist without taking distracting sips of tea and so on while I'm talking. The links to the H2 Ocean sea salt healing rinse will be in the show notes, and then a QR code also on the YouTube version of this podcast. It's excellent to help rinsing with chemo mouth or irritation in your mouth from radiation, but mouth sores and just general everyday use. I find it really pleasant and really helpful to use. I hope you do too. Thanks.
And it's not uncommon that the weight we have is pre-surgery. So patients with, whether it's colon cancer or breast cancer, I think that sometimes we have their baseline weight and they went to surgery and now that's significantly different. And so, yeah, exactly. That's one of the big things we try to catch. And then we have a huddle every day. We work closely with the infusion pharmacists. We're definitely not too isolated by any means. And so working with them on that. And then also if they have questions that pop up where they don't have time to go talk to a patient, or they identify something clinically that they want addressed with the providers, they can, instead of previously us having to walk up to the floor or page them, we're able to, they can message me on like Teams or whatever direct messaging you have, and I can just walk next door to the provider and ask them questions. So again, better access to the providers, quicker response time. So instead, we're not paging a provider and then 20, 30 minutes later we get a response back. The patient's been sitting there for that long. Now we're able to get an answer much quicker, able to again streamline things for ourselves, but also the patients, limit the time they have to sit in the chair.
Right. Oh yeah, I see a large benefit to that. So you were talking about the interaction you have with the pharmacist on behalf of the patient and what you're seeing and the mixing pharmacist. So, and I just totally lost my train of thought, so I'm going to have to edit this out. So I hope I didn't interrupt you too much.
No, not at all.
Okay, great. I'll think of it.
And then like the infusion nurses, the other thing that we interact with, like the infusion nurses. So like, they are the ones, they're seeing the patients every time they come in for infusions, and they get to see the side effects that are popping up. And it's very common that patients will, see an oncologist. They'll have not called for the last 3 weeks. They tell the oncologist they're fine, and they get down in the infusion center chair, and all of a sudden these magical things pop up that are issues that are significant. And so, again, I'm sure it's probably because the infusion nurses are wonderful at talking to patients and do a tremendous job at being able to make those patients comfortable and be able to tell what's going on. And so it happened yesterday where infusion nurse will Teams me and say, hey, this XYZ is happening. Can you come down and talk to the patient? And I'll come down and we'll kind of have a chat, and usually I can help out with whatever side effect again it is. A lot of times it's GI related. That's the majority of what I do, I feel like, is constipation, diarrhea management. But yesterday was antiemetics. They had an issue with actually just obtaining one of their antiemetics that they hadn't told anyone about. And so it was something very easy that I was able to get done in about 2 minutes and get the patient what they needed. And so having those relationships again with the entire staff throughout the center is a huge aspect.
It is huge, and it's a lot of moving parts, and it's so important that everybody understands their role and reaches out and has really good communication. One of the things I stress through all my content with people dealing with cancer and with survivors is communication with your provider is so important. And don't wait until your next appointment. And a change from how you typically feel is a change. It's a symptom. So report it, because it's always better to err on the side of caution with something like that. And oftentimes I think patients think because they were told you may experience a symptom, that it's okay to experience it when it really isn't. And they may have missed the part because they're given so much information at one time of call if you have this symptom. I think a lot of times what happens, especially with patients that are kind of morphing from the old school thought of doctor knows best to this is a collaborative conversation. I'm part of my own healthcare team school of thought, is when the doctor says you may experience nausea and vomiting, they then don't hear call us if what we prescribe for you doesn't work, because I hear people say, but the doctor told me I would experience this. And yes, they did, because they were giving you information, but you need to please report it as soon as possible. It is so important that you do that, so that we can be more on top of it, and we can keep you feeling better through your treatment, and we can keep you more online and not have to hold your treatment or delay it because of your symptoms. So that piece of communication is critical. And I think as healthcare givers, oftentimes we don't necessarily appreciate how someone interprets what we say to them until you do have them in your chair and they're like, yeah, I've been throwing up for 2 weeks every time after I eat, or I haven't been able to eat because the smell of food is really bothering me. But you told me I might experience this, so I just thought it was okay. And so once you have that type of interaction, really emphasizing a lot that it is important to communicate whenever something feels different, that can really help people stay in front. Your role is it's so linchpin to the entire process, Mark. I'm amazed with it. So you have a lot of complex interactions and a lot of complex critical thinking in your job. what kind of training did you do to become a clinical oncology pharmacist?
Yeah, so I'd say the standard route to get to where I'm at is going to pharmacy school, doing the undergrad, and then doing grad school, so 4-year grad school, so I get the doctor of pharmacy now, and then that usually gets you your license, right, where you're able to become practice, or you actually have to take the test, but get your pharmacist license and practice pretty much in any as a licensed pharmacist. Typically, to get into oncology, though, the standard route is then to do at least a first year residency, which is typically a general residency for 1 year, and usually at a hospital setting covering all disease states. Then after that, you go into a second year residency where you specialize in hematology and oncology. And so that's kind of the path I took. And then so did my training out west at the St. Luke's Cancer Institute, which is a wonderful place if you're ever looking at PGY2s. But basically did a residency out there, and then after that. Accepted the position where I'm at now. And typically things I would say, I don't know, majority, I'd say majority probably, but I'm probably biased. Oncology pharmacists go on to do is they become board certified in oncology pharmacy. So they're called like the BCOP. But in pharmacy, there's a variety of additional certifications or tests that you can study for and take exams on that basically prove that you know what you're doing, I guess, in your specific situation. So there's things for oncology, infectious disease, critical care, things like that. So I did go on and take my test and pass that, and there's renewals every so often. And yeah, so that's kind of the general path of getting to where I'm at. There's always other routes, right? I mean, oncology pharmacists are in a pretty high demand. I think we're one of the probably few pharmacist positions that aren't oversaturated, honestly. So I think we're one of the few ones that are still high demand. It's hard to get a clinically trained oncology pharmacist in a lot of settings.
So for our listeners, people such as Mark, they have 2 years of residency to do what they do as a clinical oncology pharmacist, and he has his doctor of pharmacy. That is, so you truly have expertise to be dealing with your patients and advocate for them. So what do you find most rewarding? And that's probably a hard question because you probably find so much rewarding, but what do you find most rewarding about your job?
Yeah, I think a couple of things jump to mind. So one of the big things is being able to make a difference as a pharmacist. That was one of the big things that once I wanted to go into pharmacy, which led me to go into oncology, is I wanted to feel like I was having a difference in a patient's life and being able to see that difference. So one of the things I get to do on a daily basis is talk to patients, interact with them. I get to make interventions and see their care and their lives improve, right? They're having knowledge, I get to do something that actually has a direct result in them feeling better, doing better, and I can also know by feeling better, doing better, oftentimes having better outcomes in the long term as far as survival and stuff, if they're able to tolerate treatment better. So that's a huge thing, just being able to know that I'm making a significant difference and seeing that difference play out right in front of me that's probably the most rewarding thing. Patients are wonderful. I think that's one of the other things I think people that aren't in oncology don't really understand is our job, I guess, or our workplace is a very happy environment. I feel like for the vast majority of the time, like our patients are wonderful. We get to have great experiences with them. We interact with them. We get to know them over time. We get to see them, over the course of months, if not years, depending on their situation. So you get to actually build relationships with those patients, which is pretty cool. And then on the other side of that, my more logical pharmacist brain is I love the problem solving. So when you get new indications, challenging situations, you need to work through and figure out what's the best treatment. And the fact that oncology is always evolving. There's always new studies being published, new data coming out. Everything we do from a treatment standpoint is pretty much driven by a study that you can basically reference the trial of why we're doing X, Y, Z for a given situation. So I also love that side of things as well.
That's great. So how do you work with clinical trials?
Yeah, so we have a handful of clinical trials. We're a moderate-sized cancer center, so we definitely don't have as robust as maybe some large academic centers. But yeah, we have a handful of clinical trials. My role is mostly the same thing I do. So education, walking them through kind of side effect potentials, right? Sometimes it's placebo and that. We have another pharmacist that does most of the clinical trial stuff, so that's her role. So I do more of just same thing I do for every other patient, supportive care.
Okay. So it must be really rewarding when you meet someone who, say, isn't tolerating the treatment well, and doesn't look good when you see them. You work with them, you answer their questions, you reassure them, you educate them, and then say 3 weeks later they come back a different person
Yeah,
and more
exactly.
robust and smiling and their cheeks filled in and they're coloring better. And a
Yes.
lot of that has to do with what you did.
Yes, that is by far the most rewarding. And then, I think closely behind that is patients that come in with rightfully so, like preconceived notions of what they're gonna experience. So whether like,
Hmm.
my grandpa's a great example who like he had saw his mother-in-law go through my great grandma go through treatment for breast cancer back in like the late 80s, and he's like, I'm never doing anything to treat cancer, and he had prostate cancer. So obviously significantly different treatments, side effect profiles, and as well as
Yes.
the stuff we can do nowadays. But having those conversations with patients, I've had multiple times where I've walked through the trials showing like percentage of adverse events. Like just because it says XYZ doesn't mean you're necessarily going to get it, and being able to not convince patients, but give patients maybe more accurate information of what this drug may or may not cause, what the may or may not benefits may be. I think that's also very rewarding to be able to guide patients through the information, opposed to
Yes.
maybe like a preconceived notion of what in their mind chemotherapy or cancer treatment is going to be.
It must be a wonderful experience to watch the relief and the knowledge enter a patient's face and their eyes, and you see the tension ease as as you are talking with them and collaborating with them on this life-changing uh, situation they're finding themselves in, to be the person who is helping them have a sense of control, a sense of relief, a sense of this is all going to be okay. And I'm working with some great people.
No, it's definitely probably one of the most rewarding parts of the job for sure.
Yeah. Yeah. I know when I have interactions like that, I walk away saying, I'm in the right place. I'm doing the right thing. So Mark, you're involved pretty deeply from what we talked about before we are doing this interview with some great initiatives that are happening in your state of Michigan. Can you share those with us?
Yeah, so my role is something called I'm a poem pharmacist, like the literary poem, POEM, that stands for Pharmacist Optimizing Oncology Care Excellence in Michigan. So a bit of a mouthful, but yeah, so there's about yeah, like 9 or 10 of us across the state, and our site actually has two pharmacists. So I have a colleague that also we're the one site that has two poem pharmacists. But yeah, basically what we do is we do basically what I described. We do supportive care, patient education. Different pharmacists have different niches. So most of us are focused in oral chemotherapy. We're a little unique where I main focus is oral chemotherapy, but then my colleagues' main focus is gyn-onc patients, and then we kind of share
Hmm.
everything else. So we basically do all
Hmm.
patients at our site. But yeah, we basically do patient education, supportive care, all the kind of stuff I mentioned previously, and we track all the data. We track interventions, we track adverse events, we track a multitude of information, and all with the goal of basically showing that what we're doing as clinical oncology pharmacists is improving patient outcomes. So decreasing ER visits, healthcare costs, adverse events, improving outcomes, things like that. And this all stems from uh, a prior initiative funded by Blue Cross for ambulatory care pharmacists being embedded in like primary care physician offices to treat
Hmm.
like manage diabetes, hypertension, and that showed significant benefits. So this is kind of like the next step from that realm. And so, yeah, so the program is awesome. We not only do all that stuff, that they help support us in billing. So one of the unique things that we're able to do is bill for our services, which a lot of pharmacists, at least in Michigan, definitely don't do or can't do. And so that has
Hmm.
been a huge advancement from pharmacy practice in general, is being able to actually get paid for what we do, which is very unique for pharmacy. And
Hmm.
then the other thing is that we go to conferences. We just kind of give talks on kind of reporting on our data. We have abstractors, so we have as part of being a part of
Hmm.
POEM, we have statisticians, we have people managing all the data for us, so we don't have to do all that work, and which they're wonderful at. And so we're actually at our site currently getting abstracted to pull a lot of that data to look at those markers that I just mentioned. And yeah,
So, how long have you been involved with Poem now?
just shy of 3 years. So I think I was
Okay.
the second rollout. So there was, I think, three pharmacists before me, and then I was the second group to roll out. I think we're on like our fourth rollout of
Okay.
pharmacists. And
What is the data showing so far?
yeah, it's still early. So one of the things is about 3 years out is kind of where we're looking at the data. The first results, I think we're gonna present it here in ASCO, but the one of them showed honestly no major difference between the most recent abstracts. I think the large reason for that is we're likely thinking it's because of COVID. I think it caused a lot of variation in people going to
Mm-hmm.
the ER, seeking
Mm-hmm.
additional healthcare, and you can't really, from like a medical standpoint, right? You're not allowed to like those don't count, right? You can't just say that doesn't count when you're looking at data and running data. And so there was a lot
Mm-hmm.
of COVID being the main one of variables and that affected that data. So we're pretty confident that's probably the reason that caused that. But as of right now, it did not show any significant difference pre and post. But we're thinking that's the main variable at that site. But our data,
Mm-hmm.
we have not seen our data yet.
I bet patient satisfaction is a lot higher, and sense of empowerment with what you're doing in your initiative from how you described it. What is the ultimate goal of the POEM initiative?
Just can continue the you know advancement of pharmacists being in
Mm-hmm.
that role and basically being providing patient education, supportive care, optimizing both pharmacists practicing at the top of our profession, so being able to use our
Mm-hmm.
license to the most of its ability, and then also by doing that, provide best care for patients, improve their healthcare
Mm-hmm.
outcomes. We all see what the results are in clinical trials, right? You get X amount of months based or years based on this regimen, but the more we can optimize everything else that surrounds a patient, managing their side effects, managing other comorbidities, other things like that, the more you can help the patient feel better as well as
Mm-hmm.
tolerate treatment, that you're going to improve or at least give a better shot at that treatment having to work to the best of its ability for our patients. And that's another huge thing we can do.
That is significant. Can you do a little bit of a dive into us about the importance for people to understand that oral, either immunotherapy and or chemotherapy can have just as much toxicity as IV therapy can? Because I think sometimes there's a misconception that because it's oral and it's pills, doesn't have the same toxicity profile, and it does actually require the same amount of caution and attention.
Yes, definitely. Yeah, no, that's a common misconception that it's just a pill, so why do I have to worry about X, Y, Z kind of
Right.
thing? No, I mean, a great example is like capecitabine, right? It's the same exact drug, just a tablet or whatever, a fluorouracil, which is an IV form. So it's a great example that they're the same basic chemical that's having the same effect in the body. But no, it's one of the big things with education. We have well over 100 now oral agents to treat cancer, and a lot of them aren't traditional chemotherapy. They're targeted therapy, right? They work differently. They have,
Mm-hmm.
more specific
Mm-hmm.
targets. They go out in the body and certain things, but they also can have very unique and still very significant toxicities.
Mm-hmm.
So I think a great
Mm-hmm.
class is like the tyrosine kinase inhibitors for renal cell carcinoma or kidney cancer. And so they have a very common class effect of having things like mouth sores, hand foot syndrome, hypertension, that are very real and definitely do happen. Like it's not like they don't ever happen. They
Mm-hmm.
do occur quite commonly in some of those
Mm-hmm.
drugs. Yeah, so it's very important that we tell patients and routinely that these are still significant drugs. They are still hazardous. They still have adverse events. And then the
Mm-hmm.
immunotherapy side of things is very unique as well, right? That's a
Yes, it
completely different
is.
mechanism. And
Right.
the vast majority of patients have no issues. I think it's like 15% of patients roughly have to like have some sort of steroid intervention to treat the immune-mediated adverse events, but that's a large percentage that don't have any real significant side effects, which is awesome. But the biggest issue with those is if when you do have side effects, when you do have those immune-mediated adverse events, they can be severe and fatal, right? So they're
Yes.
they're very
Yes.
significant. And so
Right.
that's always a struggle, honestly, with I don't say struggle, but like a challenge with like um, doing those educations for immunotherapy patients is trying to balance out the yes, this is likely going to be well tolerated. You don't want to scare them, but then you go through this long list of side effects that can happen and what to do with them, and that highlighting that these can be very severe, or on the other side of things, they can be lifelong issues. So like
Mm-hmm.
hypothyroidism, or much more rare, but still occurs, like uh, causing type 1 diabetes, basically destroying the
Mm-hmm.
pancreas. Those are things where they will be
Mm-hmm.
on levothyroxine for the um, hypothyroidism or insulin for the rest of their lives.
Right.
Now, that's a huge impact, especially when we're seeing these drugs used in adjuvant treatment. We're seeing it used in early stage breast cancer patients now. So not
Mm-hmm.
only was it previously with just more of the palliative metastatic side, now it's patients who hopefully, when the data shows likely, will get a cure from these regimens, but they could
Mm-hmm.
have these long-term, lifelong adverse events. Also, with the immunotherapy, those adverse events can occur well past them stopping treatment. That's one of those things that
Mm-hmm.
just because they've stopped XYZ immunotherapy drug does not mean they can't still have one of those immune-mediated adverse events 6 months, a year down the road. Now, like less likely the farther you get out, but it's still possible with the way those drugs work.
Right. And who would have thought that taking a medication for cancer would lead to someone ultimately having diabetes? I mean,
Yeah,
that's not something we're used to, but because of the mechanism of action as you described, so I'm thinking of immune checkpoint inhibitors. The T cells are no longer restricted from having the tumor cells masked from them. That checkpoint, literally checkpoint, is taken away. But what happens is then the T cells can attack another part of the body. And I know that's a simple explanation, but you can't necessarily predict what area of the body it may attack. I mean, for each type of drug, there's more common adverse events that occur, but it can be anything, which is why it's so important. If there is a change, call. If there is a change in how you feel, call. That's really important, especially with the immune checkpoint inhibitors, because the earlier it's intervened, hopefully the less severe it is. And as you said, and it is reassuring to hear that most of them are not severe. Most of them are well controlled, but there are a few that can in fact be fatal, and you want to manage those as soon as possible to avoid that. And there are some where you may end up with a lifelong condition to deal with, such as diabetes. However, on the flip side, it has the impact, the targeted impact the immune checkpoint inhibitors has is so amazing, and has advanced cancer care, as you've seen and I've witnessed tremendously over the past few decades. And there's so many more on the horizon. And I imagine that we're going to get, and we have gotten much better at managing these adverse events and also keeping people on treatment. I remember we used to oftentimes, I'm sure you can recall, Mark, halting treatment or holding it for a really long time. A lot of times now, the recommended path is to keep them on it, but manage the adverse effect. As you were talking about with steroids. Do you have any more thoughts on immune checkpoint inhibitors?
yeah, no, just those are all great points. Yeah, just emphasize like education with the checkpoint inhibitors is crucial,
Mm-hmm.
right? Make sure patients call us sooner rather than later, because the vast majority of the time it is grade 1, grade 2, and we jump on top of
Mm-hmm.
it. We can treat it, keep them going, and continue on. Or even in the severe cases, we can get it back under control, and the data is very
Right.
strong that shows even once we get under control, we can restart the drug, and oftentimes they do not have a recurrence of that adverse event. So education on that is crucial, and then also educating on patients on like if they go to the ER, if they go somewhere else and they're having an adverse event, making sure they can
Yes.
tell the providers, the ER providers, that they're on immunotherapy, because it's well documented in multiple case reports that they go into the ER with severe diarrhea, colitis, and they get Imodium and hydration. They're sent out the door, and that's not going to do anything, right? That's not going to treat the issue. And so, being able for patients, we give them wallet cards and things like that now, which the companies have been great at putting out those kind of
Right.
materials to help.
So if you are in immunotherapy, that wallet card this is to our audience, is crucial. It is crucial to pull out and show to your PCP. It's crucial to pull out and show to, say you're traveling and you are going to an ER, and they don't see your electronic health record from your hometown. And also just the initial communication when you're walking in with your symptoms before the ER doctor or APP, advanced practice provider, may see that if they do have access to your records. Pulling out that wallet card is going to get you appropriate treatment upfront. So I think sometimes people see that as not necessarily important. It's kind of there. It has a real purpose. And I'm glad you brought that up. Mark. So is there anything else? Also, I wanted to let our listeners know, Mark mentioned the word adjuvant, and adjuvant means after surgery, or you may have or after another form of treatment. And neoadjuvant means before. So you're going to have your neoadjuvant treatment, say, to decrease the bulk of a tumor, to make the next phase of treatment, oftentimes surgery, easier because the tumor has shrinked in size. And then you're going to have your adjuvant, which is after that treatment.
That's great. Yeah. Oh, and the immunotherapy agents being used in that neoadjuvant setting is relatively new, but it's hitting a lot of
Hmm.
patients and the indications that it's in now, and showing great results.
So, what do you see really as our future state in the next year or two, or even 5 years, in terms of how your practice is going to change as a clinical oncology pharmacist or morph, and also on the horizon for treatments for cancer?
Yeah, so I think as far as like my practice, I think I'm blessed to be a part of a institution up here in Munson Healthcare that like is very pro pharmacy, especially in the oncology setting. We're very
Hmm.
basically if we can do something and prove that we can make it work and it's going to help patients or the center, they let us do it, which is awesome. And so I think
Yeah,
our next steps that we've talked about doing is expanding to like having a side effect management clinic. So like we've in this, who knows when this will happen or if this will happen, but having like a nurse practitioner and a pharmacist dedicated solely to a place where patients can come in for side effect assessment, working them up and addressing them to
that's
again,
beautiful.
yeah,
That's
that's what
beautiful.
we're,
Precision supportive care.
yes, 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 exactly. And
And
so
that's
the
not
more we,
just during treatment, it can be after treatment, it can be
yeah,
years after treatment.
yeah, no, exactly. The more we can do to one, minimize the amount of side effects, with severity of side effects patients are having is huge, just from a patient satisfaction outcomes, but also keeping patients out of the ER. Right? It's it's hard to.
Yeah.
There's not a lot of resources, right? And unfortunately, going to the ER not only is expensive from a healthcare cost. Patients don't like it. They have to sit in the ER for 5, 10, 12, 15 hours, whatever it may be, depending on the given day, to get fluid or to get something that's very simple. And the more we can educate them or have resources available to keep them out of the ER, I think is helps everyone.
That's
Um,
crucial. Also, they can get exposed to viruses and other pathogens in the ER. And that ER staff, they're phenomenal. They're phenomenal at addressing those acute issues, but they are not experts in oncology care. So the side effect management clinic, they will be the experts and can really help intervene in a much more effective manner for what's happening with the patient.
yeah, and and your oncology patients, I mean, I've talked to them before where they are very upset that they don't get seen for 12 hours, but they're coming in for hydration or something maybe not as severe, and there's someone coming in with a heart attack or a stroke, right? And
Right.
there's not going to be priority as if they would like to be, and everyone wants to be, right? And so, yeah, and
Yeah.
then other things from a practice standpoint, Palm, we're continuing to try to expand sites, and so anyone out there who's in Michigan who wants to be a part of Palm, let us know. So we're more looking for more and
Okay.
more people to be involved, and then yeah, from a actual treatment standpoint, I think one of the big things we've just done recently, our great PGY2 resident, Courtney Van Housen, her main project was to start basically help our whole center go live with BiTE therapy. So like the bispecific T cell engager therapies and being able to do that in our community
Hmm.
cancer center. So, they have the risk of, CRS and ICANS and all those more CAR T type therapy adverse events that are difficult to manage if you're not a transplant center potentially. And so she helped kind of coordinate with Colton or one of our other my colleague really helped to go live with us being able to do BiTE therapies in the community cancer center. And we just got the ACCC Innovator Award for that. So that was really exciting. So that,
Congratulations. Well deserved.
yeah, it is great work for Courtney and Colin. But basically that's going to be the next big thing for, I think, for our center is being able to do those BiTE therapies in a community cancer setting, which is pretty huge. And so those therapies, but I think as far as cancer treatment in general goes, I think those therapies seem to be really taking off in um, more and more approvals are coming from more and more disease states, I think, in the near term. So I think
Hmm.
we're going to see the ability to target again more patients, harness the immune system to attack them in whatever ways they're coming in. I'm sure there's a lot of stuff out there that I'm not aware of that is also probably really exciting that'll be coming out.
Can you um, describe again what a bite therapy is and how it works?
I'll do my best. It's a bispecific T cell engager is what BiTE stands for,
Okay.
and it basically helps basically I'm trying to think of a simple way. It basically you have specific targets like CD19 is a common one, and specific targets the goal is to use these drugs to go and target specific receptors in the body, and but also harnessing the immune system with it. So if you're like CAR T cell therapy, they would use like your own cells and things like that. So you had to go
Hmm.
through harvesting cells and things like that to
Mm-hmm.
create these treatments. And the big process, right? It takes a while. It's expensive, very expensive, and there's a long wait list to get that. Now with these bite therapies, these are off the shelf drugs, for lack of a better term. So you just order it,
Wow.
right? They're not specific to a patient necessarily, but they are showing great results, like
Great.
amazing results in like the lymphoma realm, myeloma, multiple myeloma. And so we're able to do a similar thing as like the CAR T cell therapies without all the legwork. Now, maybe not still to the same level as CAR T, but the data is very promising with these bite therapies. And so, but it still has some of those autoimmune or those CAR T cell like adverse event risks, like
Yes.
CRS, like
Mm-hmm.
cytokine release syndrome and ICANS. And
Right.
so, but to a lesser degree, or a much lesser degree than
Right.
maybe the full blown CAR T cell therapies.
That's so exciting to hear. Thank you for explaining that. And also for our listeners to have that move from, say, a tertiary center that is in the city to the community centers means you don't have to drive as far. It's going to be easier. There's going to be less barriers to you having access to that type of treatment. Um, Mark, is there anything that we haven't touched on that you would like to share?
No, I don't think so. I really thank you for the opportunity to talk to you today and kind of share what I do as a clinical oncology pharmacist. And happy to talk to anyone who has further questions or reach out. I'm happy to talk with anyone.
Okay, well, we will include your contact information in the show notes. And I so appreciate your time with us here today. I am sure you've enlightened many, many people with what you've shared. Your role is so critical to people having optimal care and optimal results. And it's really wonderful to hear how much you enjoy interacting with patients. Thank you for being here.
Thank you, Jeff.
Thank you for joining us on this episode of the Everything Cancer podcast. We hope you found the conversation as insightful and as inspiring as we did. Remember, all the details about our guest, including their contact information and links to resources they've shared on their websites, will be included in the show notes. If you've enjoyed this episode, please consider supporting us by visiting our website, checking out our Patreon page, or becoming a sponsor. Your support helps us to continue to bring you these important discussions. Don't forget to subscribe to the Everything Cancer podcast on your favorite platform and follow us on social media. Always remember the information shared here is not intended as medical advice. For any personal health concerns, please consult with your healthcare team. Thank you so much for listening, and we look forward to having you back with us again next time. And for anybody that you have invited to join us, please reach out if you would like to be a sponsor. We would welcome you. Thank you.